right, Dr. Morse, we're recording, so if you want to go ahead.
All right, welcome everybody. I always forget to do this, but I'll just ask if everybody could make sure your computer and phones are on mute. And we will see if I can share my screen here. All right. Okay, so hopefully you can see my PowerPoint. So again, we do have a lot to cover today because there's been a lot of updates and changes. So if you're not with the school or health department, we'll ask you drop off just so we have time for everyone's questions. So these will be posted on our website, so it is public access. Make sure that any information needs to get passed along to your staff is passed along. First thing I was going to cover today is the updated guidance for athletic testing. This is all available on the state websites, and I'll provide all those links as we go along. All the old guidance is the same for those athletic activities where wearing a face mask is not safe, such as wrestling, cheer, gymnastics, swimming. Testing must be done 3 times a week and must be done before competitions. The addition is that individuals 13 to 19 participating in contact, non-contact sports must be tested on a weekly basis. The timing of that doesn't matter. It doesn't matter if it's before a contest or what, just once a week. There is guidance in there on what to do if testing is positive. So any athlete who tests positive with the rapid antigen testing must isolate immediately and get a PCR test within 48 hours. You can refer them to any testing center in your area. Unless they have a negative PCR on a test that was performed within 48 hours of that original positive test, they have to keep isolating. So if you have athletes who refuse to get a PCR test, are unable to get one, then they must just finish out that 10-day isolation. If they test positive, then they must continue to isolate. They can't return unless they have a negative PCR test. So if they're asymptomatic and have a negative PCR test, they can return. If they're symptomatic and have a negative PCR, they may only return when symptoms have resolved for 24 hours. That's per the state guidelines and per the CDC guidelines, which they give the link for that. I will mention that in this guidance document, it does state that when you have this positive antigen, they state in this one document, you should send close contacts home. And then if the PCR is negative, you can bring them back. However, there is the MDHHS antigen test, another document, and also the CDC guidance, which recommends if you have an asymptomatic player or person, anyone, who has not been a close contact to anybody, you actually wait to do contact tracing until you have a positive PCR. So that is actually what we recommend. If you have someone who has symptoms or who's been or had close contact with someone who is higher risk, if they have a positive antigen test, then you go full out right away. But if you're just doing routine screening, someone has a positive antigen test, and you send them home, but you're waiting for the PCR to confirm it, you can wait to do contact tracing until it comes back, unless, again, you have some reason to suspect they're at high risk for infection. Again, if you look up the CDC guidance, that is the recommendation. I do mention that one of the state's guidance documents says differently. If you wish to follow that guidance, you can. You just might have difficulties putting people out and then bringing them back and kind of that yo-yo. So, but this is actually in the state's antigen test guidance, and it is on the Safer Sports Testing Program page. So I just wanted to point that out, but this is what we do follow. So they also state that you can test other students. You can test people in, extracurriculars and things if you want to. And if you go to michigan.gov/sports COVID info, there are links on there that get you into all of this information. And if you have questions, you can send them to mdhhs-COVID testing support at michigan.gov. The turnaround on those questions is not very quick right now. On the website, they have enrollment links. They just want one enrollment per school. They have links for the specific sport. Well, they have it for water polo because there is a different enrollment for that because it is a 3-time-a-week testing. And then for non-school-based sports, they have a link for that as well. So if you get questions from the community, that's all in the same place. It talks about needing a CLIA license. That's for non-school sports. Schools are all covered by one CLIA license, so you don't need to worry about that. There's information on how to deal with your biohazard waste, how to get PPE, and then all the training and everything is on that website. So that is it in a nutshell. I know the High School Athletic Association also has all those links, and so you should have all that information. If not, again, it's on the state website. The operational strategy for K-12 schools through phased prevention was updated March 19th. So that was last week. This is where some changes in distancing recommendations came in. So the CDC states that physical distancing should be maximized to the greatest extent possible. However, they're now stating that in elementary schools, students should be at least 3 feet apart. So they're allowing you to go down to 3 feet if you have to. Again, further apart is better. In middle schools or high schools, students should be at least 3 feet apart in areas of low, moderate, or substantial community transmission. In areas of high community transmission, middle and high school students should be at least 6 feet apart if cohorting is not possible. In cohorting, you have distinct groups that stay together throughout the entire day and do not interact with other groups. So in most middle schools and high schools, I honestly don't know that it's really that possible to do that, where you have no mixing of, small groups of kids, just because of the nature of how middle school and high school works. But, I just leave that to how your schools are working. But with kids changing classes, I don't know that really can work. To just show you this, they do 100 per 100,000 is high. For us, we usually look at it per 1 million, so it'd be 1,000 per 1 million.
Hi, how are you?
And then 10% or more positivity. So I pulled this yesterday. This is how our map looks. So a good percentage of our counties are, this is orange, I know it's kind of hard to tell the difference, but a good percentage of our counties are in that high risk, the high transmission levels. So those counties we would recommend, the CDC would recommend you keep your high school and middle schoolers 6 feet apart. Again, I know everyone's doing the best they can with that. So realistically, I don't think that this changes a whole lot. I think you still try to keep your students as far apart as possible. If with the younger kids, you can't keep them 6 feet apart, this is just saying we now know that it's not as dangerous as we thought it was to keep them closer. You do want to maintain at least 6 feet at all times between adults and students, because that transmission from adults to others is higher risk. Unfortunately, we adults just seem to spread COVID more easily. So teachers and staff should keep 6 feet away from each other, and teachers should try to keep 6 feet from students. And I know that is a really challenging thing, especially with the younger kids. 6 feet should be maintained where you can't wear a mask, like when you're eating, when there's increased exertion, like singing or band or sports or exercise, and do those outside if you can. And then in any common area like lobbies or auditoriums, I added in libraries, because I think that's an important common area of schools. They remind us that desks should be facing in the same direction. I've heard some comments about people putting kids back to where they're facing face to face in classrooms. That should not be happening. Everyone should be facing in the same direction so that, you know, droplets and aerosols are hitting back of heads instead of front of faces. You should really decrease or eliminate any non-essential in-person interactions with your teachers and staff still. So do remote meetings if you can. Don't have lunches in the break room together, that kind of thing. Continue to limit non-essential visitors and volunteers as much as possible. And, you know, continue to space as much as possible on your buses. Masks are required by federal law now, or federal order. And crack windows, open windows as much as possible on those buses. That ventilation really does make a difference. Now, here's one of the big confusing things we've been getting questions about. This did not change contact tracing at all. So the definition of a close contact is still 6 feet apart. And in elementary schools where you can put kids 3 feet apart, the definition of a close contact is still someone within 6 feet. So if you are going to put kids closer together, you could potentially then double your close contacts. This is the definition for CDC and MDHHS. We've kind of agonized locally about whether or not we want to try to loosen up contact definitions to try, you know, to shorten that distance. However, over this past week, we have seen extreme increases in cases and school outbreaks. We've seen increases in variant cases. We've seen increases, just big explosions in cases. And we know there's going to be a lot of travel coming up. So we're not comfortable making any changes now. We're going to keep evaluating it. And over the next few weeks, we may be able to make some changes, but this is just not the right time to do this when we're already seeing spread, even in some of the lower grades. So long story short, close contact is still being within 6 feet of someone for 15 or more minutes cumulatively over a 24-hour period. So again, these updates from the CDC, I really don't think should change anything with what you're doing unless it has to, as you're getting more kids coming back to school. We've been getting a lot of questions, primarily requests from parents wanting us to clear kids to come back to school early so they can play in sports, basically claiming that we're not following CDC guidance. We sent out a document, depending on the health department, it either went out yesterday or it's going out today. I also put on there, just because I know exactly where to find it, with one of my health departments. If you go to dhd10.org/coronavirus/school-guidance, right near the top of the list, it says new, and then it says quarantine guidance. If you click on that, I've put together, we talked about this last week, I put together a written document explaining very detailed, and you can shorten it if you need to, but very detailed about what does the state, your local health department, and the CDC recommend for quarantine and why. So it is very clearly printed on the CDC website that the CDC still recommends 14-day quarantine. So it says your local public health authorities make the final decision on how long quarantine should last. The CDC continues to endorse a quarantine for 14 days and recognizes that any quarantine shorter than 14 days balances the reduced burden against the small possibility of spreading the virus. So the state and us at the local level have stated that while the standard 14-day quarantine period remains, there is the opportunity to reduce it to 10 days if you don't develop symptoms, you can monitor for symptoms for the full 14 days, and a new one is that there's no concerns that a variant could be involved. If we have concerns there's a variant exposure potential, then there's to be a full 14-day quarantine. The other thing is the determination of a quarantine and release from quarantine is determined by public health, not the person's healthcare provider. The healthcare provider will not know who they were exposed to, what the exposure situation was, if the person they were exposed to could have had a variant, those types of things. So they are not allowed to say, yes, you can get out at 7 days with the test. So hopefully that helps. And again, having it in writing can help. So these recommendations actually come from science. If you come out at 14 days, there's about a 0.1% chance you could still be contagious. So very low. You come out at 10 days, average risk is 1.4%. If you come out at 7 days with a negative test, if it's a negative PCR test, you're 4% chance of being contagious. Negative antigen test, you have a 5.5% risk of being contagious. We do not feel that is acceptable. And so that's just how it is. So these are the guidelines. Let me, all right, Janine, holler if you can't see my data slide here, but it should still be visible.
I can see it.
Okay, great, thanks. So just looking at Michigan here, as a whole for Michigan, let me slide, oops, I'm sorry. Trying to slide this bar and it's, okay, there we go. So for Michigan as a whole, the average has gone from 160 per million to 237 per million. And our percent positivity has gone from about 6% to 8.4%. So again, we continue to see pretty impressive increases. Central Michigan on average has been around 197 cases per million, and that's up from 105. That percent positivity is at 7.9, up from 5.9 last week. You can see we have a few counties that are quite dramatically high. Roscommon County is at 514 cases per million. We've had some significant, we've had some school-related outbreaks, which they are listed later on, and it's on the state website, so I don't feel like I'm divulging anything by saying that. We do know that that the B117 variant is in Roscommon County, and again, that is public knowledge as well. So we are working to try to enforce a 14-day quarantine in that county. So unfortunately, we do see some rapid spread with those cases in counties like that are struggling with that variant. District 10 on average is at 252. Last week, 177. Percent positivity is 8.9. Or I'm sorry, 10.5. Last week it was 8.9. Same thing. They have some counties that are really struggling. Wexford is one at 681. They have had some very large outbreaks in workplaces. We've also just very recently gotten quite a few school-related cases. And same with some of the other counties in that district, lots and lots of outbreaks. The percent positivity, especially for like Misaki, they only do about 25 tests a day. So in that whole county. So if you get a few extra positives, it makes a big difference. And so we're trying to work on ways to increase the testing. The other thing I'll mention, this is a good reminder for me, when you guys are doing antigen testing, I know it is time consuming to enter in your test results, but you are supposed to report all your test results, positive and negative. I know it's tempting to just enter your positive, but when that happens, then we get these really high percent positivities because we don't have the total number of tests done as a good denominator. And I honestly think that is what happens in some of these counties with really high percentiles, is that we just are getting the positives, not all of them. So I'll put that ask in there. Mid-Michigan district also, seeing an increase, 187 from 125 and 5.8% from 3.8%. Clinton County has also seen quite an increase in school-related cases. So again, the trend is pretty consistent. I think this might be where I'll lose. All right. You should still be able to see my screen. That's showing my red box around it, so somebody can holler if you've lost it. This is the statewide data that I've shared in weeks past. So again, we're increasing in cases. One of the things that we have been noticing now is that our hospitals are starting to get more occupied. Michigan now has the 11th highest inpatient bed utilization, up 9 places from last week, and the 8th highest ICU bed utilization, up 16 places from last week. So that's, not what we want to hear. Fortunately, our death rate is pretty stable. Our percent positivity is making a nice U-curve. Cases per million, same thing. And the hospitalization rate is now starting to curve up. It had been staying pretty stable. This just shows the hospitalization trends, again, making a upswing here. Clearly not anything like it was back in December or in the beginning. So hopefully we can continue that. This just shows the spread of the variant. Michigan has 984 confirmed B117 variants. Over half of them, well, no, just under half of them. Before it was over half of them, now it's just under half of them were related to cases in the prison system, but it is definitely moving north. I am sure we have tons more than this. It's not easy to test for, and it takes a lot of specific hunting. But anywhere you're seeing really rapid spread of cases or rapid growing outbreaks, just assume it's the variant. We do now have 2 of the South African variants in Michigan, but again, most of this is the United Kingdom strain. This is the first time, I think, since the beginning where the #1 most common outbreak in Michigan was not in our nursing homes. There's been actually a big decrease in nursing home outbreaks felt to be related to vaccinations, so that's great. But unfortunately, now schools are the #1 type of outbreak in Michigan. There's been 63 new outbreaks in K through 12 schools this past week, which is kind of a bummer. So you can see the number of these are cases, actual individual students. The majority of them have been in high school students. I pulled our numbers, and again, this would be kind of from the week prior to even 2 weeks prior, just the way reporting occurs. We've had nothing in the elementary grade level. We have 2 ongoing outbreaks, one in a county from mid-Michigan, one in a county from District 10. Ongoing outbreaks in junior high, and 1 new outbreak in a county of mid-Michigan. And then in high schools, we have 1 ongoing outbreak in a central Michigan county, and we have 4 new outbreaks accounting for 31 students. At least 1 in a county of all 3 districts at this time. Obviously, there's 2 in 1 district. So we've really had a big jump. So we have 3 ongoing, which we only had 1 last week, and we have 5 new, up from 1 new outbreak from last week. So we've definitely seen an increase. And, we have concerns that variants may be involved, and we are continually trying to get samples for testing. It takes at least 2 weeks to get results back, though. Testing turnaround time actually is a bit quicker than last week. This was 1.9 something, and this was 0.9 something last week. So testing turnaround is not an issue with response. I will mention that because of this rapid recent explosion in cases, our turnaround in terms of case investigation is starting to get hindered. So, you know, don't assume we're going to know about cases right away. Don't hesitate to let us know if you need help on something. We're trying to prioritize the 5 through 18 age group. But again, just like back in November when there was such a huge explosion in cases, we're starting to get kind of maxed out on our response time. This is just some vaccine data just wanted to share. This is statewide, so about 43% of our 75 plus crowd is fully vaccinated. In the 60s percentile have had their first dose. Many of our counties are in the 70 percentile in these older age groups for having at least one dose. So we are definitely getting there. Some of the younger age groups, though, are much less inclined to get vaccinated. So we'll continue to keep encouraging them. This, I just wanted to share, it might be hard to see, but this dark blue line is the case rate over the last 7 days. And the blue bar, the lighter blue one, is the percentage that have started the vaccination series. So kind of showing that as the vaccine series goes up, the case rates go down. I was curious as to, well, what was their case rates before? So I found this from the CDC. This solid blue line is the 80 plus crowd. So their incident, it was cases per 100,000. We're right behind the 18 to 24 and the 24 to 44 age group. So now they're dead last. So again, it does look like our vaccination efforts are definitely making a change in infection trends. Unfortunately, these are the projections that U of M had made. Let's hope they're wrong. But this is their projections from where our cases might be headed and where our death rate might be headed. To me, it just looks like they took a ruler and kind of drew it to extend with where we're at now. So I'm hoping that if we take vaccination rates into consideration, we might be a bit more of a level line than this, but just kind of a warning that we definitely are seeing a quite dramatic increase in cases. And then this I've shown you the last few weeks. Our percent of our population staying home is quite low. It's kind of down to summertime rates from 2019. So, you know, everyone's enjoying the spring weather, which is great, but, you know, things spread that way. And then the number of trips taken, again, we're, you know, kind of hitting some of those summertime and holiday time rates from 2019. So definitely not staying home and staying safe right now. So I know that was a lot of information. I'll close out of this for now. I might need to pull it up if we need a reference later, but all right. Phew, catch my breath. So I'm going to scroll back up and find the beginning of these questions here. So this is when I was talking about the sports testing. If they refuse to get a PCR test, do we do contact tracing immediately, then quarantine close contacts according to Antigen Test? Yes, that's what we've been advising. If they refuse to do the PCR, it's, well, we have to assume it's a true positive then, and then act accordingly. So they stay in isolation, you have to do contact tracing. So, and unfortunately that then disrupts a lot of time and things. The other thing too is if your PCR testing is taking a really long time coming back, and you're starting to see more positive test results come back, you can call us and we can kind of talk you through that, because that might be a sign too that it was a true positive and we need to act sooner. Do you think our recent small uptick in cases is due to humans being bad or Hope Simpsons? I like that question. So I think it is a whole lot of things. I think, you know, we started out loosening restrictions and allowing more things to happen. And when you do that, it tends to let people think that it's safe to do that rather than just saying it's not illegal anymore. And so people start doing more things that are not as safe. And then with the vaccine, I think people do get very hopeful and think, gosh, we're saved. COVID's over, which again is not true. Then the variants come into play, which are way more contagious. And spring hits and it's nice out. We want to go out and do things. And then, you know, for better or worse, there's changes in how we can gather and do things if you've been vaccinated. And I think sometimes maybe we take the guidance that you can be unmasked with others who are vaccinated to we can have a big party now. So I think it's just a big clump of all those things rolled together. So it's a little bit of both. We're naughty, hopeful people. We have a running club in the spring. Are they required to test as well? So the way I read it is any non-contact or contact athlete that is 13 to 19 needs to test. So my answer would be yes. However, you can email that question to the state just to be sure. We had a couple people who couldn't see my PowerPoint. I honestly don't know what's the matter. So if there are some of you who just can't see my PowerPoint, but everybody else can, you may want to talk with your IT people. I'm sharing my entire desktop and it seems like the majority can see it. So I don't know how else to do it. I don't know. Honestly, I don't like Teams very much. I don't understand why it doesn't work. So for sports, if they test positive for antigens, if they get another antigen test in 24 hours with a negative result, is that considered okay? No, it is not. Or do they still have to get the PCR test with a negative result? Yes, they do. So the antigen test is just less sensitive. So it's more likely to have a false positive. Well, how do I want to say this? So if you test again the next day and it's negative, it could be a false negative because they stopped shedding the virus, or it could be a true negative, or the day before could have been a false positive. We don't really know. The PCR test is just much more sensitive, and so it's kind of the gold standard. So you think the antigen test is a screening test, and when you do a screening test, you kind of expect it to be positive more often, but you don't want to miss anybody. And so the PCR test helps to really confirm it. Doing it again doesn't really fit the bill. So unfortunately, that doesn't work. How would you determine if the COVID-19 variant is involved? The only way for us to know for sure is if we get the swab sample. If it's still available, or collect another swab sample, send it to the state and they do like a full genetic sequencing. That takes a couple of weeks once they have the sample. Just getting the sample and sending it can take quite a while. It is not really meant to help with the care of the person. And honestly, by the time we get the results, usually everyone's out of quarantine. It more lets us know, hey, it's in the area. If it's in a school person, we know, hey, it's in the school. And then we know, okay, in the future, we probably need to quarantine people longer. Realistically, I think most of our areas, probably a good percentage of our virus is likely the variant. We should really just consider most of our infections the variant. But again, what we've seen is when we've had these really rapidly evolving or developing outbreaks, it is the variant. Can you tell us again where to find the letter on the DHD? Yeah, let me put it in your, and we're going to send these slides out too. So if you go to DHD 10, if you go to their coronavirus page and click on the, there's a box that says schools. That's one way to get there. There we go. Hold on just a sec. I'm going to copy and paste it into the chat box for you. Okay. Okay. I have to try to find my questions again. Okay. Okay. Are there regular health department meetings with local physicians? There's not, mainly because of the amount of territory I cover. However, there are regular meetings with the state health department and the healthcare systems. And then they are to pass on their information to their providers. I do send letters to our healthcare providers when there is something important going on. I did have that quarantine information sent to our healthcare providers yesterday because we are seeing a lot of issues with healthcare providers altering quarantine time. So they should all have gotten that. Having been in practice for over a decade myself, I know that you get a lot of stuff when you're a provider, and so not all of it gets read or remembered. So, but they did get it. And I'm going to send out a letter soon, just reminding them about the variant too, and giving them instructions on how to send samples for variant testing if they're suspicious. So I try as hard as possible to keep in contact with them, but we don't have weekly calls. Thank you for mentioning the negative reporting. I was on a statewide call with the ISD superintendents today, and I do not think that personnel from MDHHS was making that point clearly. Yeah, I am concerned about that, and we have jails and nursing homes and all kinds of other entities doing this testing, and that, again, is a big concern. If you know who was doing that call, I can pass it on, or if it was with the state, it might have been Dr. Bagdasarian or someone, but as long as you guys are hearing it, that's the main thing. I know it is time intensive, but again, it changes how your community looks. If an athlete gets a positive antigen test after a direct contact with a confirmed positive case, do they need to get a PCR? So again, if we look at, well, it's kind of hard for me to share my screen again, but in that algorithm I showed, and I just want to pull it up for my own sake to make sure I'm not lying to you here. So if someone is symptomatic or they have had close contact with somebody and they're not symptomatic, if they have a positive antigen test, there's no confirmatory test needed. So I'm looking right at the algorithm I shared from the MDHHS antigen test. So I'm going to share that link too. This is really a really helpful document. So on page 8, there's a nice little algorithm, and it says, send home, no confirmatory test needed, isolate, exclude, and initiate contact tracing. So again, so basically, if you're high risk for infection and it's positive, you can believe the results. If you're low risk for an infection and it's positive, you need to confirm it. So it has to do with positive predictive value, negative predictive value, all kinds of statistics, which I hate because I never liked statistics very much. So what do we do if we have a parent who agrees to testing but does refuse to sign the code of contact due to a disagreement with phrase that they will follow all the health department guidelines? So I don't know a lot about all the nitty-gritties of the program. So those kinds of questions I would encourage you to email to the state, because my feeling is that if they refuse to sign any of those documents, then they can't play. But again, I would have you ask the state because I don't know all those answers. What is the difference between a 12-year-old playing sports and a 13-year-old playing sports in regards to COVID transmission? I don't know. I think maybe they're trying to find the cutoff between grades. You can test 12-year-olds. So if you have a grade level where you have 12 and 13-year-olds on the same team, you can test all of them. You don't have to just do the 13-year-olds. And that is in their frequently asked question document on their website. So again, I think they just arbitrarily picked an age. Most of the data has found that kids under 10 are less likely to spread COVID, but that's just been how the studies have been set up. So again, it's really challenging to make guidelines because the data is so challenging to find what you need. I believe I know the current answer, but can you give me an overview of current quarantine protocol for school employee exposure to known COVID occurring greater than 2 weeks post-vaccination? Any different with medically fragile classrooms? So if you are fully vaccinated, which is 2 or more weeks past your last dose, whether it's your second dose in a 2-dose series or the only dose in a 1-dose series, you're 2 or more weeks past that. If you have been identified as a close contact to someone with COVID, you do not need to quarantine. If you develop symptoms, obviously you need to then isolate and get tested. The guidelines are not different for any situation. So if it's a household contact versus a classroom contact, if it's working with medically fragile, it might be a little different in healthcare. I haven't reviewed that lately. But you as an employer, if you want to make it different for your situation, you certainly can, but it's really not any different. It's not any different for any workplaces that I am aware of. MDHHS is the person. Yeah, and I can, regarding the reporting of test results, Dr. Bagdasarian is the head person for the testing procedure at the state. And I can follow up with her about that in terms of reporting negatives and positives. If a student has had COVID in the last 90 days and tests positive, do they need to quarantine? So those who have been who can document a positive test result within the past 90 days do not need to be tested and should not be tested. So if you're doing your sports program, if they can provide documentation of a positive test within the last 3 months or 90 days, you do not have to test them. And that is in the guidance. I just didn't copy and paste the whole thing into the presentation. But, basically they just have to give you a copy of their lab result or something. If they absolutely can't find it, we probably can provide it for you, or they can contact us and we can provide it to them and then they can provide it to you. If they do get tested within those 90 days and it is positive and they have no symptoms, then they do not need to isolate. So those are questions that if that happens to come up, you can call us and we can kind of talk through the situation. We are seeing an increase in cases. At the same time, the state is requiring 20 hours of in-person instruction for us to receive our funding. Do you think the MDHHS or locals will suggest to require reduced capacity per the CDC guidelines? So I'm assuming by in-person instruction, you mean, oh, okay. I remember somebody bringing this up. Yep. So your students need to have 20 hours of in-person instruction. So the CDC guidelines is now allowing you to have your younger students 3 feet apart which again, most desks, you know, if you have somebody sitting in the middle of a desk, I think desks themselves are about 2 to 3 feet wide at least. To me, 3 feet apart is probably about as far apart as they used to be. I don't know, I can't answer that. I'm thinking that they probably assume that you should be able to do it, but I don't know that they all realize how big some of your classrooms are. So I think that might just be a question that you'll have to take to the state school board or something. Different for variant. I have to go back up to your question and see what we're talking about. Different for variant. Deb, I don't remember what your first question was to be able to answer what is different for a variant. Okay, sorry, I had to scroll down. Will quarantine post-vaccination staff be different if exposure is to a variant? Currently, no, not for the variants we have in the US at this time, because the vaccines are felt to be effective enough. The other thing too is that we often don't know it's a variant at the time. If there were to be different recommendations, we would notify you and the infected individual on a case-by-case basis. But at this time, the recommendation is universal with all the different strains and variants in the US at this time. If it takes 2 weeks for a variant to be determined, how do you decide if a student or staff member needs to quarantine for 10 or 14 days? If I had my way, we'd be back to 14 days for everybody, just because of the amount of variant activity we have. The issue is as it is now, we have people that are not very happy with us for only going down to 10 days instead of 7. So I think it'd be a hard sell to go to 14 days for everybody again. What we're doing is basically going on kind of the epidemiology. So for example, like Roscommon County, we've had enough evidence to suggest that the variant could be involved in some of the school cases. So we've kind of made it universal that quarantine there will be 2 weeks. So it's more based on the situation. But again, you know, if we ruled the world, we'd just go back to 14 days for everybody. I'd also probably lock down everything and you know, cancel spring break, and then I'd have people hunting after me. So you know, what's safest and what is best for our population and our, you know, mental health and things are not always the same. So we always have to make a little bit of compromise. All right, so I've hit the bottom of the questions in the chat. If anyone has questions who are on the phone or want to add any additional, you can unmute yourself or add them in. You know, that was a lot of material today. The other thing was about the next couple of weeks. I know that I think everyone has spring break either next week or the week after. What I planned to do was have meetings the same time the next 2 weeks, but probably just not put together a big presentation, maybe be available just to give any big updates and be available for questions, but likely there'll be shorter meetings, if that sounds acceptable to you guys. And then if you have any questions in between, you can certainly contact me. All right. Last chance for questions. All right. Well, you guys have a great day. And if you're gone next week, have a safe break.